Welcome, everyone. This is the January 2022 Pre-Hospital Care Research Forum Journal Club, the PCRF. Here in our PCRF podcasts, we promote evidence-based practices by critically evaluating the latest science in EMS. We hope our discussion will help advance our practice. My name is Dave Page. I'm joined with co-hosts Tony Fernandez, Jeff Rollman, Jeff Jarvis, Bill Toon, and today we are so lucky to have the author of this paper, Dr. David Murphy, with us. We're going to be discussing fewer tracheal intubation attempts are associated with improved neurologically intact survival following out-of-hospital cardiac arrest. As always, we want to let you know that this article is paired with an EMS World Review, and that you can please tune in to that column that Dr. Fernandez writes. We also want to encourage you to use the Q&A area to ask questions, interact with the presenters and panelists, and we would love to be able to entertain those. We have a large audience that has registered for this, and we're very excited. We are recording it for those who couldn't be here with us live, and we often what we do is put it up on the website. Usually, our usual facilitator would be Dr. Remley Crow. She is at the NAMSP conference in San Diego, where many of us will join her later this week. So she is teaching and could not be here today. And she sends her apologies. We want to just dive in here. And I think the first thing would be to ask Dr. Murphy to just tell us how he came about this. Dr. Murphy has EMS experience prior to going to medical school and has done an EMS fellowship, so he is quite aware of all of the world of pre-hospital care. And we'd like to hear a little bit from you about just why you got started on this. What was the driving force behind doing this project?
Sure, thanks. Yeah, and it's a true pleasure and honor to be here. You know, not just for me, but also I think for our group. There's a large team that was really involved in this paper that I relied on heavily, and it was truly a collaborative effort. But yeah, the project itself, you know, Seattle Medic One and the Medic One program there, we are really interested in a lot of the intricacies in trying to better describe resuscitation care, particularly around airway management. And at the time, we were really thinking a lot about the sequence and timing of specific ALS procedures and what effect, if any, they may have on outcomes. And at the time, we were really looking at the timing. So, you know, the time from ALS arrival to intubation. And, you know, when we were starting to conceptualize that type of paper, there was some other work that came out of Benoit's paper, actually, that looked at the time of intubation and really provided some interesting input. And so then we kind of moved over and started focusing more on the number of intubation attempts as a very similar and analogous, also important question to look at. So, of course, there's a lot to unpack in the background of airway management and cardiac arrest, but that's kind of the distilled summary.
Love it, love it, love it, love it. In and around the concept of advanced airway management during cardiac arrest, there's been a lot of work done, right? So and you summarized some of it in the paper, which is really good to talk about a bit. The focus here in this study was the Seattle program intubates. They're very good at it. Statistically, we've seen that it can be proven, and there's been a lot of effort to make sure that first pass attempt is actually successful. Can you describe a little bit of what you saw and experienced around intubation and best practices that you feel Seattle's doing around that?
Yeah, I think, you know, one of the strengths of the Seattle program is, of course, its methodology. They've got a pit crew style for resuscitation where there's predefined roles and exact not just geographic or physical locations around the arrest, but assigned roles and expectations. So it's pretty impressive just to watch the resuscitation. Now, I will admit that, of course, this is a heavily resourced city population that we're dealing with, and so the response times are short. You've got a lot of support from the BLS crews, and so the ALS kind of falls in and overlays on top of them, and with their sequential procedures, getting established IV or IO access, working on an airway, and any medications that need to be administered. So it's almost like a really nicely choreographed resuscitation, I think. But again, I understand that that's got to be quite challenging. My heart goes out to paramedics working in very rural settings where they are working alone, maybe with a BLS provider or a volunteer, trying to manage all of these important and time-sensitive interventions. So, but yeah, that'd be my statement around Seattle.
And some people may not know this. I think Seattle has a tiered system, right? So it's not that every ambulance is an advanced life support ambulance. And they have a wonderful paramedic program where paramedics do get to intubate in the OR as well. So the resuscitations are recorded, right? Audio and not just the EKG tracing, but the audio around it. So you referenced that in your abstraction, a little bit of the sort of confirmation of some of these things into the database. We're not just relying on memory about when the intubation occurred. Somebody's actually following the transcript, looking at the times, right?
Oh yeah, all that's exactly right. So yeah, Seattle is a tiered FHIR-based system. And so, and they truly follow the resuscitation model, this resuscitation academy model of BLS owns CPR, high performance CPR. And ALS is truly a secondary, the ALS care intra-arrest is really a secondary process. And then with regard to the paramedic students, yes, they are heavily involved. It's a one-year program, so the first several months they're kind of observing, helping out, supporting, and then they start taking the reins and getting more involved in actually running the cases, or if they're the proceduralists, doing the intubations later in the year. And so I think this and also some other aspects will probably be worthwhile to come back to when we get into some of the discussion and some of the results, and because there are paramedic students involved, and that could potentially inform some of the numbers in terms of first pass success rate and whatnot, because you have learners there on the field. But and then lastly, you brought up the point about the audio recordings, and I think this is if not one of the greatest pieces of quality improvement data that comes out, and I think it is just an absolute strength to the Seattle Medical One program, how it's continued to refine and push the envelope here. It's because there's a culture, it's a just culture, and truly a culture that is inculcated, if you will, with the idea of quality improvement, and that takes a humble perspective and a lot of buy-in from paramedics, knowing that this is a system that's truly trying to improve and not oust anyone or wag a finger at errors, right? So we're truly trying to improve, and I think if there's one takeaway, getting more information. It's incredible what you hear on some of these cases that really help you get at some of the root cause of errors or processes or conceptions or misconceptions. It really is amazing. And when we go over cases, we listen to every intubation, we listen to every cardiac arrest, both oftentimes the clinicians, but also research assistants. But I've had many times paramedic students or some of the treating paramedics who would come in and want to listen to the cases with us. And I think there's a lot to be learned, and from the paramedic side as well as from the medical oversight side.
I love it. I love it. And I love the just culture part. In particular, I think that, like aviation, having the black box recording what you're doing, we need to get to the point where we're both the humility, the accountability, but the desire to really kind of look at process, not at the individual, is really just a strong message to all of us. And the cool thing is that I remember when Seattle was doing this with LifePack 5s, And I'm sure Bill Toon will open his camera up and start teasing me about, you know, the years in which we were using the LifePak 4 or you know, but there's an extra module. You know, we used to have the defibrillator, the monitor, and the recorder, and Seattle's been doing that all along, and it's a testament of just sort of the longevity and the intentionality of trying to do things well. So love it. Well, we're going to bring in Tony here to talk a little bit about methods. And he's going to walk through some of the paper. And for those that don't know this, the paper is freely available. It's in Resuscitation. And while Tony's talking, I'll share my screen. But the neat part is that you can simply go to the web and click on the link, and we'll provide the link as well. Sometimes we feature articles that you can't get because you're not subscribed to that journal or have access to it. So the cool thing about Resuscitation is really that openness. So volume 167, and take it away, Tony. Let's talk about methods.
Will do. Well, excuse me. Thank you, Dr. Murphy, for joining us today to talk about your paper. I think this is a really, really important paper, and I'm glad we get a chance to pick your brain about it today. So I think we'd be remiss if we didn't start with asking you if you can just kind of state for us your study objective and what did you go into, what was your hypothesis going into this study?
Yeah, thanks. The hypothesis is really, we were wondering, does the number of intubation attempts have any impact on neurologic survival? And that's the distilled question. Kind of a little bit of the background, of course, is, you know, there's this constant back and forth about the best approach to advanced airway management and out-of-hospital cardiac arrest. There's been the rise of better and refined versions of supraglottic airways. There's been recent trials, PART, Airways 2. I think Dr. Jarvis was involved in the secondary analysis of PART. All of these studies that have emerged more recently and provided more and more insight into what the best approach is. And of course, there's so much that's not known. And so we were just hoping to kind of pick apart one more little piece to this puzzle as we all strive to better identify how we can better care for these patients and offer them the best chance of survival.
Yeah, fantastic. And so you completed a retrospective observational study, and you collected data from for quite a long time, January 1st, 2015 to June 30th, 2019. That is a wealth of data. When you're collecting your data, can you talk to us about how you chose your patients, how you included patients for your study, and walk us through some of your exclusion criteria and how you came to those decisions to exclude these patients?
Yeah, absolutely. So if we're able to pull up figure 1, or those who have the paper alongside, you can look at figure 1 here that goes over the kind of the patient selection. But basically, we started out with all the patients that were treated by Seattle Fire Department with out-of-hospital cardiac arrest and received an attempt at an advanced airway. Again, as mentioned before, this is predominantly an endotracheal intubation attempt. Then we kind of selectively remove certain patients, and I think it's good that we're going through this because it's a pretty narrow patient population that we're really looking for. We're looking for folks who received an intra-arrest attempt at an airway management, airway device placement. And so, you know, there are patients, for example, who arrested after the arrival of Seattle Fire Department. That's not our typical out-of-hospital cardiac arrest case, right? Something was different about that patient. They had a call for another reason and then arrested in the presence of Seattle Fire Department. So that's not, that is a unique population. Next is a patient had a pulse at the time of arrival of Seattle Fire Department. So that could be that they weren't truly in arrest, or maybe they received some type of bystander AED. So those are a unique population as well. So they were removed. Then there's this BLS only treatment or no ALS treatment. So that distills down to, did they require ALS level care? And in Seattle, you know, if you have a BLS provided defibrillation, that patient regains consciousness and doesn't require an intubation, and they don't require any medications to support, say, for example, their blood pressure or anything else, that's BLS level care, that they were resuscitated, albeit amazingly or, substantially, but from just BLS level care. So that technically isn't ALS involvement. And so those cases were excluded. Patients who had a DNR were out. And then, while Seattle is the primary provider of all EMS care in the city of Seattle, there are a couple other private agencies that, if they happen to be nearby, would have, provided care or happened to witness something while, on duty. If they provided any ALS level care, then those patients were also excluded. And then finally is this concept of the initial intubation occurred after first Rosk. And so what I mentioned before is, again, we're looking at patients who received attempts at airway management during the arrest. And so if you were being resuscitated and got Rosk prior to intubation, there's something different about the circumstances in which the intubation attempt was being made. So you can imagine someone who has ongoing chest compressions is going to have probably a harder look, the intubator at least, while the proceduralist, while they're trying to place this tube, than someone who is post-Rosk. And there's no longer the constant moving of the chest wall, and there potentially could be something different about those patients as well, based on the fact that they got Rosk. So for that reason, they were excluded. And so that essentially leaves us with 1,205 patients, and we just had some data limitations in the airway registry regarding the total number of attempts in just 4 cases of those 1,200. So essentially leaves us with a cohort of just over 1,200 patients.
And yeah, just that's over that time period with the exclusions to have a population that large, I think is really useful, particularly to make some estimations like you did today. I'm looking forward to going through your results. But I always have the unenviable task of walking through the methods before we get to the fascinating results. So in that vein, one of the things that I really love about your paper is how you lay out your definitions. They're so important to work through and to really understand your results. And I think that they'll be important for our listeners to kind of understand how you define things like an endotracheal intubation attempt, how you came up with the time of the arrest, and importantly, the time of the first ventilation by in advanced airway.
Great. Do you want me to just walk through the definition section then?
Yeah, if you could just kind of just give us just how do we interpret for your paper what was an endotracheal intubation attempt?
Oh yeah, absolutely. And so this is a standard definition for basically at least for an endotracheal tube where a laryngoscopy was performed. It's truly laryngoscopy the moment the blade passes the teeth. And then when that blade is removed from the mouth is essentially the definition of an attempt at laryngoscopy. And that's regardless of whether or not an endotracheal tube was attempted or even placed into the mouth. As far as an advanced airway, such as that's not an endotracheal tube like an iGel, the moment that is placed into the mouth is the definition of an attempt as well. So has nothing to do with the endotracheal tube in terms of laryngoscopy. So that's a standard definition. In terms of the time of arrest, we estimated that by the time of the 911 call as a kind of a surrogate for time of arrest. And then the other definitions to kind of walk through I think are important are EMS to arrival time. So we looked at the time that the defibrillator was turned on, presuming that's the time that the responding crew is coming to bedside or patient side, and whether it's the LifePak 15 or the BLS defibrillators, these are all have an atomic clock inside of them, and they're able to be synchronized. And I think we mentioned earlier this audio recording that's kind of on the defibrillators. These are also able to be time synced afterward. So they have all these data pieces in unison running in background when we look at CodeSat, all these different waveforms, whether it's the ECG tracing, the SpO2 if that's on the patient, the the entitled capnography waveform, and then the ongoing audio adjacent to it.
Fantastic. Dr. Toon, looks like you have a question or a statement.
So, you know, I know Seattle is a mature system in the sense of the number of years that they've been just involved in study, and I think that that makes a difference with the mindset. So the one system I spent the greatest amount of time in, one of our biggest challenge was the definition of endotracheal intubation. And we used the exact same definition you did, but the amount of pushback that we received from the providers was astronomical with the definition. But we stuck to that as our definition in our airway registry. And we were able to get around the self-reporting nature because we actually interviewed every person after an endotracheal intubation. There was an interview by a trained abstractor and stuff. So that was able to help us since we did not record the events, which is another great tool that Seattle has, but is also the pushback from other agencies. You know, typically for that kind of oversight is just, you know, pushback against. Is there a good adoption by, now my question is do the paramedics feel comfortable with this definition, or do you have some pushback?
I think, you know, it's been standard fare in Seattle for as long as I know. So I didn't experience any pushback with the definition. I think I actually found more often that when I talked to emergency department staff, like residents, that the question of what actually is an attempted intubation is typically in the mindset of an actual tube and not laryngoscopy. So in large part, I would actually say I found the paramedic program was, and the students and ALS providers, the paramedics in Seattle, were more comfortable with the term. And I think it's probably just being built into the process. And also, you know, in our airway registry at Seattle Fire Department, there is a red cap form. So basically after every intubation, and this was this is where a lot of the data points came in for this study and others that we've worked on. The paramedics after the attempt, you know, typically the same day as the shift or maybe right after that call, they'll go in and they'll put in the data and to characterize the specific, you know, things related to that intubation, whether the indication, the medications used, the devices employed, the success, the grade view, all of these aspects of care. And on there, for example, you know, for grade view, there's a diagram showing exactly what a grade 1, grade 2, grade 3, grade 4 is. So in case there was any concern or knowledge questions, or maybe the paramedic had forgotten exactly what a 2 or 3 is, it's right there in front of them. So they just can very quickly remind themselves of what the grade view is. So that's just an example, but just to say that I think going through this process frequently and having some guidance on the airway registry form may help with some of these standard definitions and being methodical about agreement among definitions.
Thank you.
All right, so we've got a couple questions coming in from our audience about the methods. I love to see methods questions. So we did have a question about if you would expand a little bit on why you chose to exclude treatment by ALS treatment by private agencies. You mentioned that earlier, and it does probably have to do with where you were able to obtain the data from, but if you could expand on that for our audience.
Yeah, I think the biggest thing is that there's, you know, a lot of the pieces of data for this study, you know, was, you know, looking at ALS response times, looking at specific data points regarding to the intubation and the timing of them. All that kind of goes out the window if we don't have the ability to capture those data points. And to be honest with you, this is a very small subset of cases where that would occur. And you know, it's just, it would introduce probably missing data. Essentially, it's nothing about the care rendered by those other agencies. It's just a matter of being able to report data. And you know, I think it also would need to be, because this is a single agency study, essentially, we'd like to represent the care rendered within the circumstances and I guess within the agency and the standard platform for which they operate, I think it'd be important to keep keep that fairly homogeneous.
Yeah, and this is typical with data sets. Sometimes you just, not everything is linked like we would love it to be across all platforms and all agencies. So sometimes you just don't have access to those data, and it's par for the course. So we have a question about the percent of paramedics. Do you know the percent of paramedic student intubations in your study?
Yeah, not in this particular study, but I think overall it's somewhere around a third or so. It's a substantial proportion of intubations that are performed by paramedic students or trainees. Again, they start rolling out typically or somewhere around mid-year. So I think it's somewhere around a third to half of intubations are by paramedic trainees.
Great, thank you for that. So let's talk about your primary outcome. Your primary outcome of interest for the study was favorable neurologic status at hospital discharge, and you define this using the cerebral performance category scores. As we talked about earlier, a lot of our audience are budding researchers or folks looking to get into EMS research, and they may not be familiar with these scores. So can you walk us through these scores and why you chose this for your outcome?
Yeah, first is that these are commonly used outcomes to describe neurologic function at discharge. So it's nice to be able to compare, apples to apples when considering other studies. It's consistent with Utstein guidelines, of course. But a CPC essentially, or a cerebral performance category, is describing how functional a person is. What can they do? Can they attend to their activities of daily living? Do they have any neurologic or cognitive deficits? Do they have impairments so that way they need assistance to function? Or are they, severely disabled and need long-term care, or essentially comatose, right? So there's a big spectrum here. And so for relatively good or good neurologic outcome after cardiac arrest, a CPC score of 1 or 2. And so a CPC 1 is mild or no neurologic deficits, and 2 is moderate cerebral disability. So that's kind of standard fare, good outcomes after, or relatively good outcomes after cardiac arrest. So that's what we chose to work with.
Fantastic, thank you. That's a great explanation. And our secondary outcomes for your study were ROC, survival to hospital admission, and survival to hospital discharge. And as we go through the results, we'll see that I think those were important secondary analyses or secondary outcomes to analyze. So I want to move quickly, and again, we don't do some real deep dives into statistical analysis, but I do want to talk about your analysis a little bit after we hear from Dave Page.
I just wanted to add a quick plug that for those thinking about doing research, there are more and more guidelines on how to report certain types of studies. And so I really appreciated that you included that strobe guideline, so that some of those sort of standardized ways to report can get normalized, I guess, and we don't have missing pieces. So I really appreciated that, and I just wanted to highlight that. And please do jump into the analysis now, Tony.
Yeah, and more journals are actually making sure that you are abiding by the strobe guidelines, which again, I think standardization in most respects is really good. So you stratified your patients for your analysis, and you ran some multivariable logistic regression models. And for those on the call, a regression model is basically a way for you to understand the strength of association between variables. Logistic regression specifically typically has a dichotomous outcome, or things like live-die, and the multivariable part of that means that you're not just looking at one independent variable, but there could be some confounders in there, and there could be some things that you adjust for. In your multivariable model, can you talk to us about some of the things that you adjusted for and why you chose those variables?
Yeah, we selected age, sex, the status, meaning witness status, whether or not the arrest was witnessed by a bystander. If any bystander CPR was performed, we looked at the initial presenting rhythm, whether it's shockable or non-shockable, and then the time from 911 call to ALS arrival. And a lot of these are pretty standard for out-of-hospital cardiac arrest research, trying to decide, was there something unique about the cohort of patients in the variable that you're looking at? And, you know, these are common confounders. You know, just to think about an example, if there was, you know, group A had, you know, 100% bystander CPR and group B had 0% bystander CPR, you can imagine there may be an outcome. And if you don't account for these, you know, and the group that you're looking at got some other intervention and you didn't look at the bystander CPR, for example, and it might lead you to make the wrong conclusion about the outcome of whatever your intervention was. So, you know, that's a great description, Dr. Fernandez, about essentially confounding that you laid out for us. And essentially that's what we were trying to account for, try to take out potential confounders that would lead us to the wrong result.
Yeah, and we try and do our best there, but there's always points where what I like to get out on this call oftentimes is research doesn't necessarily really good is good, and it doesn't have to be perfect. And one of the things that I like to talk about, especially when we're talking about confounding and adjustment, is were there things that you wish you could have included, but you weren't, they just weren't available?
You know, there's one big limitation of this study. I mean, there's a few. There's the idea of we'd love to have a randomized study on this, but of course that's impossible. You can't randomize someone to have a missed intubation attempt. So that's.
I don't think there's an IRB in the world that's going to approve that.
For a reason, exactly. So outside of that, you know, there's this idea of resuscitation time bias, and I don't know if you want to get into that now or later on, but I think that would be the one thing that I think has just kind of lingered with me.
The length of the resuscitation.
I'm sorry, can you say that again?
The length of time that the resuscitation took place.
Yeah, well, maybe we can just get into it real brief. I'll try to be brief. So there's an idea in that. And let me just start with, there's this idea of immortal time bias, and this is more commonly seen in critical care literature. So basically, or for post-arrest care. So someone who survived, say, a cardiac arrest, went to the ICU, and then died very quickly versus someone who's lived for a period of time to receive an intervention. And I'd give an example of maybe targeted temperature management, or someone who got therapeutic hypothermia, right, got cooled. If you died before that intervention could happen, by definition, you did not get it. And so you would be in the non-TTM group, right? And so there is this idea that if you survive long enough to get an intervention, it's going to probably end up favoring or showing bias towards benefit for those who got the intervention. Now, when we're talking about cardiac arrest research, it's kind of the opposite of that, in that there's some unique interactions of time and the interventions to people being resuscitated. And so first, just to lay these out, the longer you're resuscitated, or basically the longer that you don't get Rosk and the longer that you don't yet have ceased efforts, means there's a larger period of time where paramedics can do some type of intervention, whether it's additional medications or an attempt at an airway or multiple attempts at an airway. Second, if once you get Rosk or once efforts are terminated, of course, there's no more chance for interventions. Those are kind of two sides of the same coin. And then lastly, there's this idea that if one of those interventions, and say epinephrine, if you administer epinephrine and it leads to earlier Rosk than you would have otherwise gotten, that has an effect on the exact outcome that we're looking at. So one of the secondary outcomes is Rosk. So is it the fact that the intubation led to Rosk, or is it one of these other variables, this epinephrine in this example? Anyways, all that to say that there's a kind of a complex interaction of all of time and some of the procedures or interventions that are done during arrest that that can affect the duration of the arrest. And so put that in lay terms, longer resuscitations are associated with worse outcomes. And so the longer the resuscitation is and the more interventions that occur during the arrest bias us towards more harmful effect or worse outcomes.
It's fascinating to think of all of the variables. There's no magic bullet, and we keep looking for one, you know, the high dose epi back then, or, you know, but then we learn the quality of compressions wrecked an entire, you know, process because we were doing one of these things incorrectly. But is just compressions the quality of the compression the only thing? I'm curious about a variable just because when I think of intubation and I think of difficult intubations and I think of multiple attempts, you do a nice job in the paper to say, set yourself up so that you can be successful. And then you want to do it early, but not too early because we really need to get compressions really going. And so there's this sweet spot of we got the compressions going. Don't worry so much about the epi, but get the airway. And I wondered about the weight of the patient. And I know estimating weights is one of those things where, particularly lately in the news around ketamine, you're going to look at a patient and they're on the ground, and how do you know really how much they weigh? It gets hard, but it is one of those factors that could help us say that person might have been a difficult tube, or did the paramedics actually record the grade? And could that have been a variable that said, look, you know, because you're sort of left with this concept of why those second and third attempts? Is it because of movement with CPR and the difficulty in placing a bougie, for example, which you mentioned as a way to improve it? Or is it that, you know, it was truly there are other factors, because let's face it, people who are obese are difficult to intubate and probably have comorbidities that make them less likely to survive. So is this a surrogate? Is the intubation attempt a surrogate for this is a person who probably is got a lot of other variables?
Yeah, I think that's, you know, that is one of the residual questions of this, of course. Is it truly the number of attempts that's the, you know, and I guess more of an independent factor in outcome, or is it another confounder for some other component of this patient, whether it's a difficult airway or some other patient or operator characteristics? I think you nailed it right on the head there, Dave. These are the questions that we're still struggling with, and you know, I think this study has led the Seattle Fire Department to kind of further look into root cause analysis and trying to figure out what's unique or different about these specific cases that had more attempts, right? So
yeah, interesting. And Dr. Jarvis came on here too. He's anxious to jump in too.
So Dave, I think you have a really good point there. Is the lack of first pass a surrogate for something else? One way you could look at that, which is a challenge because you have to have these data elements, is looking at BMI. One way Dr. Murphy and his colleagues did it was look at CL grade, and it didn't look like that made a difference. I think the reason I'm not terribly hooked in on this being a surrogate for something else is if you look at the other trials, most notably PART, which I was really pleased to say Dr. Murphy pointed out as one of the reasons they did this study and got to looking at it. We saw that 2.9% survival improvement, short-term survival anyway, with King LT, and we didn't know why. The thing that jumped off the page at least me, and it seems like a lot of people, is that the first pass success in that study was really low, 51% versus 90%. And that was a randomized trial. So BMI would have been randomized equally between both groups. Indeed, it was. So that's the reason I'm thinking it is a little less likely. Now it's just a guess. It doesn't prove anything. The way to really prove it would be, one, randomize it, which, as Tony pointed out, is not going to happen. And then the second is to, if you had the data, which is always one of those nice things you wish in retrospect that you had, if you had data on height and weight, you could do BMI.
Fascinating.
And I think, by the way, they do a pretty good job of discussing that exact thing in the discussion. I was very pleased. I just wanted to take the opportunity to say how much I like this paper. Wednesday at NEMSP, I'm doing a top papers talk, and this is definitely one that's on there. One thing that I wanted to point out was the reproducibility of this, if you will. There are some specific aspects about your system that may or may not translate to other systems. The most notable one is that you have a very high survival rate. So it's not clear that if your agency had a lower survival rate, there would be a difference. And this is just a math thing. Well, there's not as much benefit to be had. I kind of doubt it. I think this probably is a real issue, but you can't be sure. And then the other is, what if you have an agency with a higher first pass success, or who has already tried to optimize their intubation issues? Would you see the same thing? And it's interesting, we actually didn't see this result. I went to try to replicate your study with my data, because I wanted an excuse to go from 2 attempts down to 1 attempt, and I didn't see it in ours. Now, our overall survival rate is lower than yours, which may be one of the things, but the first pass success is higher, which may be one of the things. So it's with any study, there are all these extra questions you get at the end of the study. So I think it's fascinating, and I'm really glad to see this work. I think you did a great job.
Love it, love it, love it. And the questions are pouring in, and we want to get to results. Just a quick question: did the ETI attempts from Michael Dam? Thank you. Did the ETI attempts occur during the 30 compression phase? So I think he's saying, were the patients intubated with CPR ongoing? And I think the answer is yes.
Yes, yes, indeed.
Yeah. And is it possible that patients who are difficult to intubate are also difficult to ventilate? Is from Chris Ryther. Maybe they likely suffer from hypoxia or a peri-arrest problem. And that's a great question, because it's the pre-post intubation, and oxygenation issue, which he's a great researcher, Chris is, and I think he's pointing that out. Not sure that you have an answer for that, but it's definitely a good comment.
Yeah, I totally agree. That is a good comment. I don't think from this study, at least, we have the ability to really comment on ease or difficulty, or really any quantitative metric about the ventilation strategy, or any numbers to discuss. It's truly just about placement of the tube during an arrest. But I
imagine that Seattle controls for ventilatory rate just because of the studies that have already been out there around hyperventilation. Is that a correct statement? Is there some way in which ventilatory rate is definitely watched?
It's watched and it's considered, and actually there's a number of projects looking specifically at ventilation patterns now, but again, it's not involved in this study.
Okay.
So I think. Oops, excuse me. I was just going to say, I think we're chomping at the bit to get to your results. I'd want to open it up to any of our other panelists if they have method-specific questions. If not, then I just want to, again, congratulate you on a great study. And I'll turn it over to Dave to start talking about some results.
I went off camera because I thought, he's going to cover results. Well, jump in, Dr. Murphy, but I've got them up on the screen. So 44% of the cases achieved Rosk, which is great. And then here, I did notice that the number of the quantity of patients that received a second attempt and then a third attempt at intubation decreased quite a bit. So that's nice, right? But the punchline here is that the ones that did actually get further attempts had unfavorable outcomes. So the fewer, the better. And I'm going to just put up the tables, and maybe you can walk us through particularly the table 2 or table 1, I believe, is here.
Yeah, sure. Let's go ahead and walk through it. So just to look at study population. So on the top of the table here, you're looking at the overall group of patients, and then it's stratified by the number of intubation attempts: 1, 2, 3, or 4, 4 plus. And then on the left side, it's kind of specific characteristics about the patients. So if you look at age, the mean age was 62, and the majority of patients, 68%, were male. If we look at the out-of-hospital cardiac arrest Epstein etiology, the majority of these, somewhere around 85–90%, were medical cause. The witness status was pretty stable, around a third of patients. Bystander CPR, again, was around 60% or so for the cohort. And then the use of defibrillation, was around 36%. And the initial rhythm was shockable in about 21%. Now, when we get down to the bottom and we look about other process measures, and we selected epinephrine as a kind of a surrogate, an ALS intervention. How does that play out? Is that different among the groups? So that was very stable, and the ALS arrival time to first epinephrine was 6.3%, and ranged between 6.2 and 6.6% across all different groups. So it's a very stable process. Whereas when we look at the very bottom at the intubation or airway specifics, you see that in this study, and again, it makes sense, Seattle's intubation centric, or is a primary means of advanced airway placement. Overall, 97% of cases ended with an endotracheal tube, just 3% with a supraglottic device, and in our system it's an iGel, and then less than 1% had a cricothyrotomy or a BVM at the completion of the EMS care. And then looking at the time to a final advanced airway placement, that was variable. And so I think that's what you were getting at, Dave. So that was highly specific to which kind of category of number of intubation attempts the patient was under. And so when we take that and look at outcome, so again, the primary outcome is a patient-centric outcome of neurologic survival. We found that with each subsequent attempt, the percentage with favorable neurologic outcome went down. And so for patients who had a single intubation attempt, they left the hospital neurologically intact at 11%, whereas patients who had a second attempt, that number went down to 4%, 3% with 3 attempts, and 2% with 4 or more intubation attempts. So from there, we basically took all of these data points, ran it through the pre-specified multivariable model that we had discussed previously with Dr. Fernandez. And we basically found that for every subsequent attempt at intubation, the likelihood of a neurologically intact survival went down, and with an adjusted odds ratio of 0.41. And when you look at secondary outcomes, they followed the same pattern. And we did have one pre-specified subgroup analysis, and this was stratified based on whether they were shockable and non-shockable, and essentially the outcomes persisted. So that's the meat and potatoes of our outcome.
Love it. And one of the things that I learned to do, and maybe for people who are trying to make heads or tails out of a lot of numbers, one of the things that, if we're looking at the number of intubation attempts, correct me if I'm wrong, and there's plenty of people who will jump in here, Bill Toon, and particularly loves to tease me, but I love to tease him too. We need to look at whether or not these same variables are true across the types of demographics or variables that we know matter across the intubation attempts. In other words, if there had been a very large percentage of for some reason older or people in the public or drowning patients or witnessed versus unwitnessed. And what's really nice about this across the board is that they're very similar populations, right? Nothing jumps out as being incredibly, inordinately different about the number of intubation attempts versus, for example, witnessed or unwitnessed. These are slight differences that don't appear to matter across this, right? PEA, asystole, versus VFib, it really the same amount, the same percentage of patients are getting intubated or getting second and third attempts, even based on rhythm. Is that a fair statement?
Indeed, yeah, I think that's very fair. The one thing that we noticed was that age was a little different. So I don't know if you look at the top of the table there, you'll see that so age seemingly got sorry, male sex is what I was meaning to point out. So overall it's 62.4%, but age seemed to be sorry, geez, I keep saying that, male sex. So there were maybe more men in a couple of different components, like the let's see, in 3 attempts there was 71%, but both of these, age and gender, were things that were accounted for in the logistic regression.
Cool. Okay. Love it. And one of the questions in the chat is, what about would video laryngoscopy improve? Video laryngoscopy was not measured in this particular study, and it's not being used in Seattle. Jarvis might have a thought about video laryngoscopy, but at the moment, that was not part of the conversation, right? Okay. Tell us about this nice histogram. It's kind of an interesting. This was in the paper, and just it's interesting to visualize it this way.
Yeah, I think the nice thing about this visual is it gives you an idea of sense of time. So again, looking at the x-axis is time minutes from ALS arrival to the final airway device placement. And then on the y-axis, you're looking at number of cases, and then kind of stacked on top of each other are the number of intubation attempts. So at the very top, there's the graph for 1 intubation attempt, and then below that 2, 3, and 4. And you'll see the total number. Each of those dots essentially represents an outcome. So, and the color designates the type of outcome. So the dark purple, for example, is a CPC 1 or 2. That's a good neurologic outcome. So those cases are more frequent, more rare overall, which you can see across they're the dots along the bottom. And you can just see visually more of those dots with 1 intubation, and they become more sparse as you move down. And then the larger kind of cohort, or the time to the device placement, moves laterally to the right across that x-axis. So I think it does a number of things. It kind of gives you a feeling or a good sense, visual sense of where the majority of cases lie. You can see how many had first attempt success relative to the total cohort, and then you see the outcomes and then also overlaid on top of time. So I think it does a nice job of conveying a lot of information with a single visual.
Awesome. Okay. I know Jeff Rollman and Jeff Jarvis were on. Bill, jump in.
Oh, let the others go first. I can wait. They were before me.
Go ahead, Jeff.
Oh, thank you. First of all, just wanted to thank you, Dr. Murphy, for your excellent study. Very well done work. So I have a question. I know we've kind of all been thinking about this. Dr. Jarvis has brought this up, but of course we all know we want to minimize intubations. We don't want to be getting to that second, third, fourth, and in an ideal world, we wouldn't need to go past that. But I was wondering if you have any thoughts on this magic number. I know American Heart Association has already said low performing systems don't even try. They kind of prefer supraglottic airways, but you are in a very high performing system, but still we see that dose dependent relationship. So I was wondering your thoughts. Do you have any sort of protocols of should paramedics only be trying once or twice, or what are your thoughts on when it's time to move away from endotracheal intubation?
That is definitely the question. I think the intuitive question and of this study that comes up, and so there's kind of two ways to look at it. First off, I think it's important to say that the study didn't specifically describe or compare kind of the idea of an early transition to a supraglottic airway. And because there's just 3% of cases, it didn't even allow us to take a look at those cases that did end in supraglottic airway to make any kind of statement about the timing of transition and outcome. So first off, I guess I just have to say out loud that this study didn't specifically look at that or suggest that it's necessarily a superior approach. I think some of the prior work that had been done definitely suggests that, maybe whether it's a supraglottic device or an endotracheal tube, it's not a major driving factor of outcomes. I think that that's what we learned from the part in airways too, and really that resuscitative care should truly focus on BLS. As again, I say this again, Resuscitation Academy teaches that the BLS owns CPR, and that is where the money's at. Survival is from good, high quality performance CPR. And so things that we can do to support that, driving up compression fraction, early defibrillation, telecommunicator CPR, bystander CPR, I think all these things are probably the most fundamental piece. But of course, there's like implications that this study has overlaying with the literature. And I think there's kind of two parts. One, I think efforts that can increase first pass success are super important. We brought up the idea of standard use of bougies, and there's a paper a couple of years ago from Latimer out of our study group at Seattle Medic 1, where there was a protocolized implementation of first attempt bougie use for all intubation attempts. And that showed essentially a 9% increase in first pass success for cases of cardiac arrest. Now, they looked at it for all types of cases, but just looking at the cases of cardiac arrest, that increased first pass success. And what we've learned from this study and others, patients with a pulse, patients without a pulse, the number of intubation attempts does seem to matter. So things that can promote first pass success make a lot of sense. I think I'll caveat one thing, and it's probably worth coming back to in a moment, but first pass success is a very important outcome, but I think there are some potential flaws with it in of itself. Not all first pass successes are created equal. By that I mean, if you take a 4-minute attempt, is not the same as taking a 10-second look, realizing you've got the wrong size blade, and then coming out, bagging the patient up, trying to, again, pre-optimize, and then going back in quickly with the right equipment to place the tube quickly. So I think there's a qualitative distinction here about the quality of the attempt, and just to say that while first pass success is important, I don't think it's in and of itself always the right outcome to be interested in. For patients with a pulse, there's kind of this idea of first pass success without hypoxia. I think that's really the one that's worthy of pursuit. Now, again, in the setting of cardiac arrest, you don't have or SpO2 monitoring, right? These patients don't have a pulse, so that's less of an issue. But then the second part, which you brought up, is this idea of when do you transition to a supraglottic airway, and how many attempts are the right number? I don't know that we know, right? I think that this study should, provide some additional information for every unique EMS agency to decide with their training capacity, their priorities, and their system what the right approach will be, and when and if they want to transition to exclusively or earlier supraglottic use. I think those are all very appropriate questions to be asking, and I don't know that I sure don't know the right answer, but I don't know that there's a right answer for every system either.
I think you did a marvelous job of also saying in the paper, we absolutely have to think of every possible way to make every attempt count and get good at what we do, which is, I think, good for all interventions in all cases. Let's make sure we get it right the first time. And strategies to optimize that are the way to do it. I wish we had 30 more minutes, because we're just barely able to get to some of these super cool things that are really important. And I'm going to ask the panelists to unmute and give their 30-second exit takeaways. What are we learning from this? I will say important, and you mentioned this in the paper, that association does not mean causality, especially with retrospective reviews. So we don't think that that attempting is actually causing, but it might be a surrogate for. And it looks like my video froze too. Go ahead. Let's do Jeff first, and then Bill.
So my takeaway on this, first off, it's a great paper, and I really, really like this. A 59% reduction in the odds of neurologically intact survival with each additional attempt. That's the takeaway, and that is very meaningful to me. I have really been tormented by the PART paper, and even though we did a reanalysis of PART looking at first pass success, I think the methods on that were fundamentally different than the methods used in this paper. And honestly, I like the methods you used in this paper better. I think when you can answer a question in the most simplest fashion, I have a tendency to really put more faith in those results. So I think you have done a really great job here in explaining some of the results we were seeing in PART. Strong work.
I'll say this, I want to thank you again for this paper and sharing your information and your insights. It strengthens when you read something like this. But the thing that I don't want lost on people is what you talked about, which I don't think we really emphasize enough, is it is the basics that matter. And I really want to see systems, to me, the system should focus on telephone CPR, bystander CPR, AEDs in the public. I think when a system is looking to improve, not only should they carefully measure what they're doing so they know how to get better, I think it's that front end that we still need more work on, because I think if we could avoid people, A, going into cardiac arrest, or by the time the EMS arrives, they're awake and talking because someone used an AED during that electrical phase of the cardiac arrest. I think that's where I think our money needs to be. Teach people how to do chest compressions, get those dispatchers doing that work universally. It's just still not happening universally. Thank you again, wonderful paper.
And we are just about at time. This is a fantastic paper, and I can't thank you enough for joining us today. I can't say it any better than the folks did about what's important to take homes of this paper, but I did just want to say thank you again for not only writing the paper, but for joining us today. I really appreciate it.
Fantastic. Well, I echo all those thoughts and wish for there to be more and more research, because the outcome of this says, oh, couldn't we study this with video laryngoscopy and next steps? Are you involved in more research now? Do you have one in the cooker?
I personally don't, but there are several projects ongoing at Seattle Medical One and even King County EMS, and some of which I think starting to get at the ventilatory strategies that I think will be quite interesting to come. I'd love to see a randomized trial of the second intubation attempt, or third, somewhere where we would be able to randomize a subsequent attempt to see if that early transition may make a difference. But to be honest with you, in large part, I don't think that the exact type of plastic that's used to deliver oxygen to a patient matters quite as much as, again, those primary resuscitation activities, closed chest compressions, compression fraction that we've all talked about here. And also just to point out that, people that are in cardiac arrest are a tremendously diverse population, right? Whether their baseline health status, comorbidities, the cause of their arrest, and then the circumstances to some extent of and how the care is rendered. I think these all play a huge part. And so to think that just the type of plastic makes it different on outcome, I think doesn't make sense. But I think how we do it obviously may do so. And I think that that's kind of one of the takeaways from this study is that we need to do what we do and do it very well, because there is a potential for harm. And I have to presume this is a real thing until we've got future studies that can maybe get at some of that resuscitation time bias, or if there's another confounder here. But that's sort of my takeaway. Again, thank you so much for having me. And again, on behalf of the authors, we were delighted to be here. And I'm so thankful to my mentors and collaborators back in Seattle here. So again, thanks for having us.
Love it, love it, love it. We want you back. And of course, we want everybody to replicate this study and tell us if it worked similarly in their system. And really great takeaways. Please read the paper. There's a whole section just on the team dynamics and actually getting an airway positioned properly so that the first attempt works. And please don't be afraid to do even laboratory research with paramedic students in the classroom to see what tended to improve these first pass success rates. Well, we have come to the hour. We're actually a little bit over, but who cares, because this is so important. And so we hope you've enjoyed learning from this particular journal club. We hope you'll tune in the future, and please share it with other interested EMS professionals. We archive them at prehospitalcare.org and have the future podcast, January 28th. We have one on situational awareness, which definitely, and in teamwork also, is huge and will affect outcomes of cardiac arrest as well as many other things. So join Dr. Megan Corey on Friday, January 28th at noon Central. And we are live each month on the second Monday of the month. We'll tune in again for a clinical podcast on February 14th, Valentine's Day. And we are just very proud to be able to host this. The PCRF was established in 1992. It is dedicated to the promotion, education, dissemination of prehospital research. We believe in using science to advance EMS. And our listeners, our hosts, our authors are all EMS professionals worldwide who are driving evidence-based practice. So please support us in creating a culture of science in EMS by participating in our forum, our journal club, and our symposia, our workshops. I think together we can really make research more accessible and understandable. So without further ado, the opinions expressed in this podcast belong solely to the participants and not necessarily to the Prehospital Care Research Forum, UCLA, or any of our sponsors. Thank you for tuning in. See you next time.